This is the interview of Dr. Ralph Cloward. That's being done on April the 29th in Nashville, Tennessee at the time of the meeting of the American Association of Neurological Surgeons. Dr. Ralph Cloward has been a member of the Harvey Cushing Society, our predecessor, for many years, and a noted neurosurgeon in Honolulu, whose influence has been tremendous in the practice of neurosurgery and also in orthopedic surgery for his contributions to spinal surgery. Dr. Cloward, I wanted to ask you first a bit about your educational background and your childhood and all. I had not been aware that you had been raised in Salt Lake City in Utah.
Yeah, I was born in Salt Lake City, the LDS hospital.
And you'd mentioned in your curriculum vitae that you were a descendant of the original Mormon settlers there.
Yes, my great-grandfather, Thomas P. Cloward, was one of the first group of Mormon pioneers that crossed the plains from Missouri to Salt Lake Valley, arrived on the 24th of July in 1847 under the leadership of Brigham Young. Thomas P. Cloward was the the shoemaker and made the first shoes in the new Salt Lake Valley. His son, Jacob Elijah, was my grandfather, was sent down in southern Utah to pioneer and establish a settlement there. My father was born in this little village that they started. He had 9 brothers and sisters. There were 10 in the family. My father went to medical school. His name was Ralph E. Cloward.
Was he the first in your family to enter medicine?
Yeah, he was the first doctor in the family. In those days, the medical schools in the States were 2-year schools. He went to the University of Utah for 2 years, then went back to Baltimore to the University of Maryland for his last 2 years of his medical training. My dad went back to Utah to start his practice in 1913 in a small town in eastern Utah, and he practiced there for 4 years before World War II. World War I, excuse me. And he joined the Army in the Medical Corps, and the next year was sent to France. And he was a doctor out on the battlefield, the mobile ambulance units, and saw all the fighting of the last months of the war. After the armistice in 1918, he remained in France for a year with the AEF. They were the American soldiers that were kept there to kind of clean up the army. Then he returned to the States and stopped in Boston and specialized in eye, ear, nose, and throat. It was a 6-month course.
Which hospital was that, by the way?
That was the Mass General.
Mm-hmm.
And he went back to Utah, to this little town that he had practiced in as a family doctor, and set himself up as a specialist. But he had no business because no one knew anything about tonsillectomies and mastoids and the like. So the Army offered him a commission if he came back into the Army. So he re-enlisted in the Army, had 3 tours of duty. The first one in Minnesota, in Montana, Fort Snelling, Montana. Then he went to Minnesota for 3 years, and then he was transferred to Hawaii. In the meantime, I stayed in Utah and grew up there on my grandfather's farm.
That's where you took up some interest in music, I understand.
Yeah, that is an interesting story. I worked all one summer when I was 9 years old to get enough money to buy a bicycle. And when school started, I had $9.85, and I sent my mother down to the hardware store to buy my bicycle. And she came home with a little black box about this big. And I said, "Where's my bicycle?" She says, "Well, I bought this instead." And in the box was a clarinet. Well, I cried for 3 days. And I hated that thing, but after a while, Mother got me interested in it, and we got a school teacher to teach me how to play the clarinet. And I became a musician. And from then until I was 14, when I was 14 years old, I took the musician's union examination and got my union card. And when I started high school, I got a job playing in the Salt Lake Symphony. So I was a pretty good musician.
Well, when did you go out to Hawaii for the first time?
Well, my dad was transferred from Fort Snelling, Minnesota to Tripler Hospital in Honolulu. And I was going to high school in Salt Lake, so he wrote and asked me if I'd like to go to Hawaii with him. So I went to Hawaii 1926, in May of 1926. Dad stayed in the Army for 6 months and then resigned and went into private practice with 5 other Army doctors and formed a clinic. And I started my university at the University of Hawaii in the fall of 1926.
Just as you were turning 18.
When I was 18.
Yeah.
And the 2 years I was in Hawaii, I spent most of my time in music. I had several jobs. I played with the symphony, I played the Royal Hawaiian Hotel, I played for dances, I led music at the university, their musical orchestra. So I made enough money to put myself through medical school.
For some of us older people, that's the hotel where later Arthur Godfrey used to record from, I think.
Yeah, that was the Royal Hawaiian Hotel.
Yes.
Yeah, I played for that hotel when it opened on the 2nd of February, 1927.
Yeah. Had you given any consideration to taking up music as a profession? Or
Oh, absolutely. I was going to be a musician for the rest of my life.
I see.
And my father was continually trying to influence me to go into medicine and be a doctor. And I cared less about that because I loved music. I was a good musician. I was making a lot of money. Why should I be a doctor?
Well, what made you decide to enter medicine?
Well, 2 things. Number 1 was talking pictures. Before that, all of the music for theaters and for movies and so on were pit orchestras.
Right.
I played for the theater in Honolulu. But when they got the talking movement on movies, then all these musicians were out of a job. And that kind of made the future of music a little bit hazy. And then I went back to Utah after 2 years of the University of Hawaii and got out of the influence of my father and made up my own mind that I wanted to be a doctor.
But that earlier influence must have prevailed, though.
Oh,
still.
yes, surely. So I finished my college at the University of Utah in 1930 and went into the 2-year medical program at the University of Utah. In 1932, went back to Chicago, Rush Medical College, and had my last 2 years of medicine and 1 year of rotating internship before you could get your MD degree.
Just out of curiosity, how much difference did you find between the School of Medicine in Utah and Rush at the time you made that transition?
Well, it was altogether a different situation in those days. The first 2 years of medicine was anatomy, physiology,
Right.
chemistry, and that sort of thing. The last 2 years were in the big schools back east, and those were your clinical years.
Yes.
And that's where you took up surgery and medicine, pediatrics and pathology and things of that sort. So it was a altogether different situation the
Yes.
first 2 years compared to the last 2.
But essentially, do you think Utah's basic science instruction was more or less on a par with that at Rush?
Yes. Well, I shouldn't say yes, because at that time Rush was a 2-year school, the 3rd and 4th year. And they didn't teach the subjects that I learned at the
I
state
see.
school.
I
see?
wasn't aware of that.
Yes, we got our fundamentals in a state school, and then we had our clinical years in the schools back east. Now, my dad did the same thing. He took his first 2 years at Utah and had his anatomy and physiology and so on. And then he learned how to be a doctor back in Maryland.
When was your first real exposure to the nervous system?
Well, that's a very good question, because I was always intrigued with the nervous system. And when we were studying anatomy, the second year of medical school, we were asked to make a map of the central nervous system. That is the brain, the spinal cord, and the peripheral nerves. Well, I was so intrigued with the nervous system, the map I made was 6.5 feet long and 3 feet wide. And I drew in the spinal cord, the brain, all the peripheral nerves, all the tracks. And I spent hours and hours, and I turned in the most beautiful chart of anybody in my class. So much so that the professor gave me an A+ and asked me if he could keep my chart and hang it up in the anatomy room for teaching purposes.
Did you get to sign it at the bottom?
Oh, yes. My name is right at the top. So when I got into my last years, I took extra courses in neurology.
Who was in charge of neurology at Rush then? Do you recall? I don't remember.
His first name was Washington.
I just don't
Well,
remember.
when I got into my internship, Dr. Eric Olberg was the neurosurgeon at St. Luke's Hospital.
At that time in Chicago, in the private hospitals, I think only he and Dr. Davis, Loyal Davis, as
That's
well
right.
as at the University of Chicago, of course.
That's right. Then Dr. Verbruggen had just got his appointment from, he was up there with Dr. Adson.
He was at, right, and Dr. Verbruggen was at Presbyterian Hospital.
Yeah, he went to
Yes.
Presbyterian Hospital, and he was my teacher at Rush.
Did you ever play any duets together?
Oh, yeah. Oh, absolutely.
He played the cello.
He was a cello player.
What did your service at St. Luke's and exposure to the neurosurgical patients of Dr. Olberg's further capture your interest? And
Well,
decide
yes,
you
that my work as an intern under Dr. Olberg got me interested in going into neurosurgery. And when I finished my internship, Dr. Olberg had arranged with Percival Bailey at the University of Chicago. And I went down and saw Dr. Bailey and had an interview with him, and Dr. Bailey took me on as one of his residents. And I spent 3 years at the University of Chicago at the Billings Hospital with Percival Bailey. And Dr. Busey had just come on with Dr. Bailey 2 years before.
Well, your arrival at the University of Chicago was not very long after Dr. Bailey had gone there from Boston. I think he had gone there in 1930,
Yes.
about then. And Dr. Olberg had, I think, arrived in Chicago about 1931 or possibly 32. So the neurosurgical specialty was just commencing in Chicago, really.
Well, that's true. Dr. Bailey, I think, was the first neurosurgeon there. And he went directly from Dr. Cushing to the University of Chicago. Robert Hutchinson was the chancellor of the University of Chicago, and he was very controversial in his educational ideas.
He didn't like science.
That's right.
Yeah.
Dr. Bailey stayed at the University of Chicago for 10 years, from 1930 to 1940.
Yes.
And during most of that time, he tried to get Chicago to give him a separate unit, a neurosurgical unit in the university, because he was training residents. But they would never do that, because Dr. Femister, who was chief of surgery, was a very strong personality, and he wanted to control the practice of surgery and all of its branches.
Yes.
So he was the king of surgery, and Dr. Bailey could never break down that control of Dr. Femister and get his own department.
Well, there were some outstanding people on the staff there, both in the basic neurosciences, more or less, and also in the clinical work. Dr. Buchanan in neurology, who I think primarily had an appointment in pediatrics, did he
Yes,
not?
yeah, Dr.
And
Buchanan was in the pediatric
He was a
department.
splendid teacher.
Marvelous teacher and an excellent neurologist.
Yes. And then there was Professor Cloward. You may have met
Cleaver,
him.
yeah, he was a
And,
physiologist.
Stefan Poljak.
And Poljak.
And then there was...
You remember those names?
yes, well, I met them.
Yeah.
Unfortunately, I didn't meet Poljak.
Dr. Carr.
And Dr. Herrick, C. Judson Herrick.
Yeah, he was a
had been.
Presbyterian.
Right. And then there was another fellow, Halstead, was there, I believe, at the time.
I didn't know
He
him.
had developed some psychological testing before angiography was available to help localization of disease in the cerebral hemispheres.
That was
It was quite an unusual
quite a
grouping of people.
pioneering era of
Right.
some very great men at that time.
Now, at the time that you completed your training at the University of Chicago, you had told me earlier that you had already decided that you had every intention of returning to Honolulu and
Yes,
to enter private practice. But
My father had started a clinic with these doctors, and they expected me to come back and go into the clinic and where I could practice medicine with my father. So that was my intention during my last years with Dr. Bailey.
But then after completing your training in Chicago, though, you mentioned that you'd spent about 6 weeks visiting other neurosurgical centers.
Yeah, Dr. Bailey, I went to him when I was finishing my training and ready to be turned out into the world, so to speak, and I told him I didn't feel confident that I wanted to go out by myself and face all the neurosurgical problems that I would in an area where they knew nothing about neurology and neurosurgery. And I asked him if I could have another year's training, and he said, "No, Cloward," he said, "I've taught you all I know, and from now on, everything you learn, you're going to learn by the school of hard knocks." He said, "You go on out there to Hawaii, and if you get problems, you'll have to solve them yourself." Well, but he said, "What I'll do," he said, "I will arrange for you to visit all of the major neurosurgical centers in the country, and you can learn some of their ideas that you didn't learn from me." So we spent the month and a half, my wife and I, in a little automobile, and we rode from city to city and spent from a few days to a couple of weeks with all the major neurosurgical centers and got acquainted with all the big shot professor neurosurgeons in that era.
Who most impressed you of the ones you visited?
Well, our tour included St. Louis with Dr. Ernie Sachs. Glenn Sperling was in Louisville then. We went to Richmond, Virginia, and saw Dr. Coleman and Dr. Crutchfield. We went to Boston, to Baltimore, and I spent 10 days with Dr. Walter Dandy. We went from there to New York City at the Neurological Institute. And then from there to Boston to see Dr. Horax. From Boston, we went to Penfield's clinic at the Neurological Institute in Montreal. I spent 2 weeks with Penfield, watching him do his cerebral stimulation with a patient under local anesthesia. Fantastic experience. We visited Dr. Ken McKenzie in Toronto, Canada, who was an excellent neurosurgeon, and Dr. William Cohen was working with him. And I learned a lot of...
How old was Dr. McKenzie by that time, roughly?
McKenzie was a good teacher, and an excellent teacher, and a good surgeon. And being a Scotsman, he was also a good golfer.
I understand he had a good sense of humor, too.
Oh, he sure did. So I spent most of the time with Dr. McKenzie on the golf course. But I did have a few days with Dr. Cohen and found what a fantastic surgeon he was and a technician, making rounds with him at midnight and that sort of thing. We went from there down to Detroit and then back to Chicago.
So you spent some time at Ann Arbor with Max Pete, too, or not?
No, I just called on Dr. Pete and Dr. Wink Craig. I didn't spend any time with them, just to get acquainted with them personally.
Was there a pretty wide variation in the techniques that each of these surgeons used?
Oh, not only
surgery?
technique, but personality. Extremely different characters in the way they handled their patients and particularly their behavior in the operating room, their technical ability, and there was just like day and night from one clinic to another.
Who were the best, in your opinion, technically at that time?
Well, of course, Dr. Penfield was far above all the rest of them.
By being meticulous?
Yeah, meticulous. Very, very careful, very tender surgeon. Of course, he was doing all these big brain operations and stimulations under local anesthesia and talking to the patient while he was operating, and real gentleman and a real scholar. Technically, I think Dr. Walter Dandy was, I would consider probably the roughest surgeon of the bunch. And that was surprising to me because Dr. Dandy wrote so much, and he wrote many books and many papers, and he had probably the world's greatest medical illustrator.
Yes.
And the pictures and the illustrations in all of his publications, everything was just so beautiful and so precise that I expected his surgery to look like the pictures in his books, and it was just the opposite. He was a very rough operator, he was a very fast operator, and altogether different than I had learned from my professor, who was probably the best surgical technician that I had seen in all of my travels.
You mean Dr. Bailey?
Dr. Bailey was just like a watchmaker, the most careful, tender, gentle surgeon of any I'd ever learned.
Also with the patients?
And with the patient the same way. I consider him almost like a second father to me. And if I ever became a good surgeon or a good technician, I can give Dr. Bailey all the credit.
I'll be darned. After you returned to Honolulu, I imagine having a neurosurgeon suddenly in the midst of the medical community there was somewhat of an adjustment for you and for them.
Well, I was introducing a new field to medicine. The Hawaiian Islands were quite primitive in those days, of course.
You don't mean headhunting, though, or anything like that?
No. No, but there was no neurologist or neurosurgeon, and there was no one there who knew anything about those particular specialties. Any brain surgery or spine surgery was done by the general surgeons. I went into a clinic with my father and 5 other doctors, and there were 2 other young fellows that they took in the same time as I did. The internal medicine doctor would send me a patient with weakness in his legs and numbness and so on, and I'd make a diagnosis of a spinal cord tumor, localize the tumor, expect them to refer the case back to me for surgery, and I'd never see the patient again. A week later, I'd ask Dr. Strode, the surgeon, whatever happened to that patient that you let me examine? Oh, we sent it up to Dr. Strode, and he took the tumor out. See, he was a general surgeon, and he'd been doing all this type of surgeon for the people in the years before, and they were not sending cases to me. Brain tumors, nobody could make a diagnosis of a brain tumor. That was usually made by they were treated by the internist, and he'd always make a diagnosis of epilepsy or heart attacks or something.
I assume you did the first pneumoencephalography, ventriculography, and cerebral angiography in Hawaii.
Well, we were doing, of course, encephalograms. Dr. Dandy started in 1918.
No, I meant in Hawaii itself, though.
Yes, I was doing pneumoencephalograms and ventriculograms. the angiogram, Agasmanese started the angiograms 1936 in Portugal, but I don't think I did angiograms probably until the mid-1940s. So all of my diagnostic things were with air.
Had you done the first myelography, do you think, in Hawaii?
Oh yes, I did the first myelogram. There were very few myelograms. Now I was talking about disc cases. During my residency, Dr. Bailey operated on 2 ruptured discs. And this was 1936, 37.
About the time Mixter and Barr.
Mixter and Barr started this in 1934, but it didn't get around to the brain surgeons.
Right.
I remember Dr. Bailey took 8 hours to do his first disc operation. Well, when I got to Hawaii, the first thing I did was go to the pathology department and ask the pathologist how many brain tumors that he'd found. Well, he says, we usually don't open the skull. The doctor asking for an autopsy wants to know whether the patient had a heart attack or the liver or something, so he said, we don't open the skull. I said, well, would you mind if I came up and took the brain out of all autopsies that you did? He said, no, I'd love to have you do that. And of course, Dr. Bailey was a neuropathologist, and I'd spent a lot of my time studying neuropathology with him, and I missed this. So every time we get an autopsy, I'd go take out the brain and put it in a crock with formalin. So then our residency program there, on Sunday mornings, we'd have a brain cutting session, and we'd go through all the brains and make the diagnosis. And I was finding brain tumors like crazy. I think I found a dozen brain tumors in the first 2 months that I began taking the brains out. And these people had been diagnosed as heart attacks by the pathologist. So I introduced neuropathology to Hawaii in that way.
Well, this in part, plus the referral of some patients to a general surgeon, led you to establish your independent practice. And
yes, I was unsatisfied with the group, and so I told my father I was going to resign from the clinic and open my own practice, because clinics in those days would never refer a patient out of the group, and people outside the group would never refer patients into a clinic.
Yes.
It was a very definite wall. And I thought, well, I'm the only brain surgeon here, and if I'm going to get referrals from all the rest of the state, I've got to get out and get away from the clinic, because I'm only getting referrals from the doctors in the clinic.
yes.
So I wanted to serve more doctors, so I resigned from the clinic and opened up my own practice.
How long did it take to build up a practice to a satisfactory volume?
Well, immediately. I was with the clinic 3 months, and my referrals from the rest of the community, of course, grew quite rapidly. I was giving talks at medical societies and showing cases of brain tumors, and the tumors were being referred to me.
Were there a higher percentage, at that time, maybe a disproportionate percentage of benign brain tumors, meningiomas, compared to what you later experienced? Because of their accumulation over a period of years, perhaps?
Yes. I reported my first 100 brain tumors in the Hawaii Medical Journal after I'd been there for a little over a year. As I recall, I think the benign tumors ran around 57 to 60%, and the others were the gliomas. I had some fantastic tumors. I had one patient whose tumor had been operated on in 1911, and I operated on the recurrence in 1941.
Who had operated upon the first occasion?
Dr. What was his name?
In which city?
It was in San Francisco.
Oh, Dr. Nafziger.
No, way before Nafziger,
Oh.
1911. I think
can't
his name
help
was
you on that
Rogers. Anyway, this tumor had been growing in this man's head for 30 years. And I published this, it's in my bibliography, 30 years duration of a
Yes, that's
meningioma.
what it listed here.
In 1911, meningiomas were called sarcomas. and they were thought to be
Yes.
malignant.
Right.
And this patient had a frontal lobe tumor, and to be able to get all his sarcoma out, they had taken out his tumor, taken all the bone that was involved by tumor, had taken out his eye because it had invaded the orbit. So he had nothing in his, he had no eye socket, no eye. And the man grew his hair down over one side of his face to cover up this big defect. And he became he was a certified public accountant and worked for the state, and real smart guy. But he developed epilepsy and went to the mental institution, and I saw him over there and did a ventriculogram. And I took his tumor weighed 267 grams. A huge tumor.
It must have been a very difficult dissection too, with the bone flap left out and the orbital roof defect. And
Well, he didn't live long enough, about 2 years after that operation.
he was still invasive. And
But I started patching up skulls with tantalum plates
what year
after
was that?
Pearl Harbor,
After Pearl Harbor.
1943.
Well, on Pearl Harbor, on December the 7th, rather, where were you that morning? Were you playing tennis or golf? Or?
Yeah. Well, Hawaii had sort of anticipated some trouble from Japan, because Japan was being very aggressive at that time and fighting China and going down the Pacific. So we did some training during 1940. I think the doctors were pretty well prepared for some kind of an attack, but when it finally came, it was a big surprise to everybody.
Well, do you recall where you were?
Oh yeah, it was a
again?
Sunday morning, and it was 8
Yes.
o'clock in the morning, and I was out mowing the lawn. We lived up in the valley where we could see the ocean down over Pearl Harbor, over Waikiki.
Right.
But Pearl Harbor was much farther down the island, and we couldn't see the Pearl Harbor area. And I was talking over the fence with my neighbor, and we could hear some firing. The Navy had target practice. They would drag targets across the sky and then shoot at them. And the ammunition they used was not real ammunition. And the puffs of smoke from these fake bullets would be white. Well, we could hear all this shooting, and we looked down, and these were black puffs of smoke. And my neighbor says, that's real ammunition they're using. They're shooting at somebody. And he'd hardly said that when we got a big loud report over the radio that the Japanese were attacking Pearl Harbor. And then right after that, they said, will the following doctors report to Pearl Harbor immediately? And my name was the third alphabetically. And my wife was in the kitchen making pancakes, and she screamed at me, and I came in and heard this report over the radio. So I got in my little one-seated Ford and headed for Pearl Harbor. And that was the beginning of a 4-day surgical marathon.
Why don't you tell us a little bit about that, the type of casualties that experienced by the Army compared with the Navy, for example, and the evacuation of the wounded subsequent to your surgery, and
Well,
your triage of the patients.
yeah, the Japanese had brought 2 aircraft carriers 6,000 miles, and the planes had taken off from the carriers, and their project was to destroy the United States Navy. And by doing that, then they would have control of the Pacific. And their plan was to put a bomb on every one of the battleships. And unfortunately, most of the United States Navy was bottled up in Pearl Harbor at that time. They were on maneuvers, and they were all inside Pearl Harbor, and the Japanese knew this. So the bombers were after the military targets. When I arrived at the Tripler Hospital, you see, the Army and the Navy and the Marines were separate units in those days, and they never talked to each other. And they had their own facilities and their own fighting service. The Navy hospital was way on the hill. That was a new 400-bed hospital, been opened a year before. The Army hospital was a 250-bed hospital, the old Tripler hospital. And that's where they put the soldiers. Within an hour after the bombing started, there were over 1,200 casualties admitted to a 250-bed hospital. And they were all on stretchers laying out on the lawn under the trees. Well, I rushed out there in my little car, and I opened the door of my car and stepped on the ground, and there was a great big puddle of blood on the driveway. And it sort of met me as a shock that this was the first time in the history of America that a foreign enemy had shed American blood on American soil. Well, I rushed into this little hospital, and they had the operating rooms on the upper floor. And there were 2 operating rooms. They had 8 operating tables in each of these rooms, and it was just bedlam. And all the civilian doctors and a few Army doctors were in there trying to take care of the casualties, and they pushed a pair of gloves and a gown at me, and they said, "Help this guy." And some fellow, the patient had his abdomen ripped open, his intestines were hanging down over the table, and I was helping him put his guts back in, and I did that for about 10 minutes, and then the triage lieutenant spotted me, and he said, "Oh, Dr. Cloward," he said, "we've fixed up a place for you to do the brain surgery." So they put me in a small little room, 15 by 18, where they delivered the babies. And of course, the women had been all shoved out of the hospital and taken their babies, or if they were in labor, it didn't make any difference, they sent them all home. And they fixed this little room up for me to do my surgery. I had a cautery. I had a suction apparatus that they used to aspirate the infant's throat, and that was the strength of my cautery, or my suction. I called my office girl, who was a neurosurgical trained nurse, and told her to get my craniotomy set and get out there as soon as she could. And so she came with the set, and we started operating. And I worked for 4 days, round the clock, 24 hours. We'd spend 10 minutes leaning against a door sill while they shaved up the next patient. I learned to sleep in medical school standing up. So we did one case after another. In between times, I'd go out into on the front lawn and pick out the cases that I thought that I might be able to help, that had a chance of surviving. If a bomb fragment had wiped off half of a man's skull, there was no chance that I could help him. So I'd choose only those that I felt had a chance of survival.
How many operations did you perform during those
Well,
4
in that
days?
3.5 days, 24 hours a day.
Did you not have any time to sleep?
No,
Really?
I just kept right on going. I was a pretty husky guy in those days, and
It's amazing
I can
what
take it.
epinephrine or adrenaline will do, too.
adrenaline. Yeah. Well, I think my list in that time, I had 43 craniotomies I did in those 3.5 days.
Then following that, the patients would be evacuated back to the mainland.
Yes, we kept them in the hospital for about a week, the ones I'd operated on, and I was making rounds with them every morning. Then they put them on boats and sent them back to California.
You said that earlier that there was no blood available for transfusion. There was plasma, I assume, wasn't there? Or at least
No,
some?
they hadn't started to transfuse plasma.
Nothing?
Nothing but whole blood.
Mm-hmm.
And the whole blood was given directly from one patient to another.
Yes.
We had started our bone bank a few months before Pearl Harbor,
Mm-hmm.
and we did have a blood bank. They did have a blood bank, but I think there were maybe 15 or 20 pints of blood in our
Certainly
blood
not
bank.
for
and
1,200.
So literally we had no replacement blood.
Yeah. Well, you remained the only American neurosurgeon
For the
in
duration.
the so-called Pacific Theater.
Yeah.
Until a second doctor with the Navy came along, Dr. Walker, in
Yeah.
44.
Yes, I was the only neurosurgeon in the whole Pacific until January of 1944.
Mm-hmm.
And the Navy sent Dr. Exum Walker from Atlanta, Georgia, to come and help me take care of the casualties that began to come in when the United States Navy was rebuilt and we took the offensive in the South Pacific to drive the Japanese out. The casualties were flown to Hawaii on the C-54 airplanes, which was an ambulance airplane, and we took care of the casualties. We'd get a batch of casualties, and about 2 weeks we get another batch. And Exum was at the station at the Navy Hospital. Tripler Hospital, as it is today, a big 5,000 bed hospital, wasn't built until way after World War II. It was opened, I think, 1948.
But you were conducting your private practice at the same time.
Yes, I went out, I went like all the other guys in Honolulu, went out to the recruiter to join the Army and turn my services over to my country. But I was instructed to see General Richardson, who was the military governor at that time. And the general told me that he had had a directive from Washington that I was not permitted to put on a uniform, but I was to be stationed in Hawaii under the supervision of the Army, the military governor, where I would be able to take care of the civilian neurosurgery as well as the military. So I stayed in Honolulu for the 6 years, and I had 2 hats, and they kept me very busy. The armed services turned all of our high schools into hospitals, and within about 2 weeks after Pearl Harbor, we had 7 new hospitals in the city where they put Army, Navy casualties and civilians. So I was making rounds in all these hospitals and operating at the same time. So that was my 18-hour-a-day vigil that went on for 6 years.
And then 1946, I think it was 46, you told me earlier that a Dr. Bennett joined you.
Yes, after the war was over and after the Japanese gave up and after the atomic bomb and all that sort of thing, then I became a civilian neurosurgeon again. We had a tremendous influx of people into the islands right after the war ended. There had been thousands and thousands of soldiers and sailors sent to Honolulu and trained to engage in the offensive in the Pacific Islands. There was one camp there, they had 10,000 soldiers, and they had to train them in their amphibious training as well as their jungle training with live ammunition. And up in the jungles around the base of the mountain on the other side of our island, they were shooting at these soldiers, you know, trying to cut their way through the jungle. So we got a lot of casualties from them. There was another project, and I want to show a picture of the fractured skulls. All of the oil they used to run the United States Navy was sitting out on the surface in these big oil barrels. And the Japanese dropped an incendiary bomb in each one of those, and they all went up into black smoke. Well, the Navy had to have oil to run the Navy, and they weren't about to put them out on the surface there where they could get shot at again. So they decided to build oil barrels down in the ground, underground. Right above Pearl Harbor, there's a big mountain ridge, an old volcanic flow. And the rock in that ridge is a very, very hard rock. So they hired a lot of hard rock miners to come up there and dig these barrels to put the oil in. And they contracted to build 13 barrels. They were 250 feet in diameter and 300 feet deep out of solid rock. Well, when they got 13 of them, they decided that wasn't enough, so when they finished the job, they had 21. And it took 2 years to finish that oil barrel. And this was inside of a huge big fence, and the people that were inside the fence never went outside, because this was strictly a secret that no one knew about. I probably had 2 or 3 depressed skull fractures a week out of that job. Somebody knock a rock over the edge of the barrel and it'd fall down, hit the guy on the head and cave his head in. I had one patient, somebody dropped a monkey wrench, big monkey wrench like this, He went down just like a plummet, went through the patient's hard hat, through his skull, right into his brain. And they brought him into the hospital with this wrench sticking out of the top of his head. Fantastic case. This guy was back to work in about 3 weeks. The puncture in his brain missed his longitudinal sinus by about a centimeter. It missed his motor cortex by about 1.5 centimeters. Went into a silent area in the parietal area of his brain. And we cleaned up his brain, and he healed up and went back to work. Fantastic case.
Your first interest in involvement in the development of posterior lumbar interbody fusions occurred, however, during World War II in 1943. How did that interest come about?
Well, we'll get on to the spine. I'll just give you a note or two about the wartime problems. Our big problem was losing patient skull. The local people that had head injuries at the Pearl Harbor bombing were going around with big holes in the top of their head. And we had been told that someone was inventing a new metal that they could put in the body that would give no reaction. So the tantalum appeared on the scene late in 1943. Codman and Shurtleff were the first ones to put out the tantalum
plates, I think.
Well, all different kinds of tantalum.
And,
they had mesh
right.
and screen and screws and powder, and particularly the flat tantalum plates of different thicknesses. I had an engineer from Pearl Harbor who had lost a big piece of his head. And when the tantalum came out, I had him come in, and I took a couple of pair of pliers and tried to bend this flat piece of metal into some kind of a contour plate that I could put in this fellow's head. And it made his head very bumpy, looked terrible. So he came down to my office and he said...
a phrenologist might have fun with that.
Yeah. He said, if you've got an old skull, he said, I'll build you an anvil that you can make these plates out of. So I had an old skull and marked some marks on the skull. And a couple of weeks later, he came in with this piece of brass about so big and 1 inch thick. It weighed 35 pounds. And he dished out 3 dishes in this thing. And then he fixed a clevis sort of punch that he put in the corner of the plate that I could punch holes in the metal. And that proved very, very useful. So the very first plate I hammered out on this anvil, I put in his head, and I got the most beautiful contoured plate you can imagine. Well, from 1943 until about 1974, I stopped doing tantalum cranioplasty. And in that time, I must have put plates in 5,000 people. These skull fractures from the oil barrels, those guys all got a nice little tin plate in their head. And we'll show you in the video some of the cranioplasties and the tantalum plates that we used to fill defects.
You had gel film and gel foam, I suppose, too, during the war. They did.
No, we had no gel foam, no thrombin.
They were introduced.
Didn't come until the 1950s.
Really?
Yeah.
Okay. It was developed in World War II for the European theater.
What I did do with the Pearl Harbor casualties was use antibiotics, and we had a erythromycin. I don't know, what was it? The first powder of antibiotic.
Mesulfa?
The sulfa drugs, yeah. They sold it to us in heavy crystals. We had to get a mortar and pestle and grind these up into crystals, and then we had to sterilize them.
Sulfanilamide.
And sulfanilamide, and we used this sulfanilamide powder. And I sprinkled that in the brain of all the patients that I did these open casualties from the accidents. So that was the beginning of the antibiotics that went with the war wounds.
Well, when you developed your own bone bank, Now, was that in conjunction in any way with the cranioplasties, or
No, not at all.
entirely with the spinal?
We'll get off of the Pearl Harbor and the craniotomies and so on. I did my first disc operation right after I got to Hawaii, because I'd done one with Dr. Bailey. And we opened the dura and found this lump in front of the dura, and then cut the dura transversely and took this piece of disc out.
Was that diagnosed on
a myelogram?
On myelography.
Yeah, we had that real thick stuff we used for myelogram that you couldn't remove. Then I started doing treating sciatica by taking the disc out. And for the next 5 years, all of my disc cases were plantation, most of them were plantation laborers that made their living bending over planting sugarcane. And they'd come in with a sciatica, and I'd do the myelogram, go take out their little piece of disc and put them back to work. Well, it became very apparent and very soon that these laborers were coming back complaining, well, you got rid of the pain in my leg, but my back still hurts, and I got a bad backache, and I can't do this kind of work. And it took me about 5 years to realize that the operation I was doing to cure the sciatica was not putting these laborers back to their job.
Well, not restoring the normal anatomy, more or less.
Well, no, not making them pain-free so they could work.
Yes, sir.
And that's what I was interested in primarily, so I had to give this a hard thought. In 1940 was the first time I took the disc out and replaced it with a bone. There was a big hole down between the body of the vertebra, and I'd taken out a large piece of disc, and I cut off the spinous process and took a little bone out of the iliac crest and put down on the disc space. And the idea was, of course, to try to get the two vertebrae to grow together and make a solid fusion.
Did it?
I had an orthopedic surgeon who was doing posterior fusions with fibular grafts, but they were horrible things. The patient was in a cast for 6 months and so on. My first case died of a pulmonary embolism 10 days after I operated on her. And this was probably related to the prone position and pressure on her iliac veins. But she was getting ready to go home, and the nurse went into her room, and here she was belly down across her bed, stone dead. And I thought, well, it's my fault. I did it. I was operating in no man's land, doing something that I wasn't supposed to do, and that scared me.
Sure.
So I didn't try that again until 1943. And I did my first PLIF then in 1943, where I intentionally took out half of the disc and put in 2 bone grafts that I'd taken from the ilium. And very shortly, within a couple of years, I had good success with those. They fused very well, and the patient's back pains went away. And I increased the operation where I put in more and more bone grafts. And then working on both sides of the spine, I could put in 4 or 5 bone grafts. And I've found very soon that the rate of fusion and the rapidity of the fusion depended on the quantity of bone that I'd put in the disc space. And the operation was a big success right from the very beginning.
Has anything over the years changed, either in your technique, a significant change in your technique, or success, or in any way?
Well, let me answer your first question. In 1946, we decided that we'd use cadaver bone. There were several reports in the literature at that time where they'd been treating animals and found that they could preserve bone and then put it back in the animal and it would grow. So I went to the lady in our blood bank and asked her if she'd help me with a bone bank, which they did. So I started my bone bank in 1946, and we would take the bone from a cadaver that we had an autopsy permit. We'd take it under sterile conditions in the operating room. Then the bone would be placed in a solution of blood plasma, which the blood bank lady gave me, and we'd put it in the incubator and culture it for 24 hours and then take cultures from the plasma. If the plasma was sterile, then we'd take the bone and put it in a deep freeze and keep it frozen until we got ready to use it. And that was my bone bank for over 20 years. And we depended on the autopsy material in the hospital as our source of bone for our donors. If anybody died in the hospital, I got the first crack at the body. They take the body from the room right up to the operating room, and I had permission from the pathologist to take the iliac crests out and use that for my bone bank.
But later, with the introduction of the anterior cervical fusion, you drew less heavily on your bone bank bone.
No, not true. Not true.
Did you continue using it?
We had to give up our technique when we lost our cadavers. They stopped doing autopsies because of the legal situation. So I had to take the bone out of the body under unsterile conditions and then find a method of sterilizing it. And we hit on to sterilizing the bone with ethylene oxide gas. Right. This, when used at a low temperature, would give us a bone that was absolutely sterile. It would kill any kind of cell, whether infectious, cancer, any kind of contamination of the bone would be destroyed by the ethylene oxide. And so we did a lot of experiments with ethylene oxide gas and finally developed our bone bank. And all the commercial bone banks, I published this paper in 1978 after 4 years of using ethylene oxide gas. And all the commercial bone banks that have been developed around the country since have used my technique of sterilizing with ethylene oxide. The PLIF operation and the technique of the PLIF operation has not changed. When I worked this operation out within a year or so, the idea was to remove the entire disc by an interlaminar approach, to spread the space between the lamina, to get to the disc, to retract the dural sac so you could take the disc out, take the cortex off the body of the vertebra and replace the disc with the bone grafts. And we did that on both sides, so we filled the whole interspace with cadaver bone.
Did you
Now, these grafts were cortical grafts on both sides and on the end. So they're tricortical grafts put in a vertical position. And you put 4 of those in the disc space, and the patient stands up and puts weight on them. And they fuse very rapidly.
Did you employ this on anyone who was having a lumbar disc procedure for the first time?
No. For the first time. My first disc cases were just discectomies.
Yes.
When I started to do the interbody fusion, my plantation laborers never came back pushing my doorbell.
Yes.
They stayed on the job and kept on working.
They had to.
And I decided I had a good operation because I was curing somebody, and I mean curing them so they could go back and do heavy work and had no further trouble. I read a paper at the Harvey Cushing Society meeting in 1946 on my first 100 cases. And my success rate was 94%.
Over
and I had followed
what period
these
of time, no?
I had followed these cases for 10 years, and I had a good follow-up from them. And I thought I had a good operation, and my patients loved it, and I did because I didn't have a lot of feedback, see? Well, my paper was accepted by my brethren at the Harvey Cushing Society with stone silence.
Disbelief, do you think?
Absolute, not only disbelief, but disagreement. I got no applause, I got no comment.
What do you think was the main issue of contention?
Well, the main issue of contention was expressed by my friend Jimmy Watts, who came from Virginia, and with his broad Southern accent,
yes,
he got up and said, and I quote, "We are neurosurgeons, and as such, we should confine our activities to the trephine and the rongeur and leave the hammer and the chisel to the orthopedic surgeon." And he got a standing ovation.
But Dr. Sperling and some others in neurosurgery at the time certainly were making contributions to disc surgery.
Dr. Sperling wrote a very excellent book with Dr. Keith Bradford, who was one of my trainees with Dr. Bailey. And Dr. Sperling put in his book that if the disc operation that he described in his book, that's the discectomy, if it doesn't cure the patient and the patient returns with symptoms, refer the patient to your nearest competitor. That's quoting Dr. Sperling.
That's not a very nice thing to do, though.
Okay.
Did you employ the posterior lumbar interbody fusion thereafter as a matter of routine whenever you operated upon a person the first time for a herniated or extruded lumbar disc?
Yes. I have very stubbornly and adamantly claimed that the only way to cure the patient with back problems and sciatica is to replace the disc with a bone graft and get the vertebral bodies to grow together. Now, the success with this operation in the very early days was so dramatic compared to just the discectomy that I just told myself I'll never take out another disc again without replacing the disc with bone grafts. So every operation I've done on lumbar discs since 1946, and that's 40 years or more,
And to the best
I have done the interbody fusion, and this includes, well, we expanded the operation with to the spondylolisthesis, which is a fantastic result with spondylose, and then later on the spinal stenosis came along, and I developed a technique of opening up the spinal canal without doing laminectomies and doing interbody fusions if the disc is part of the stenosis. So I probably have had more gratifying success from my standpoint as a practitioner rather than the experience of others with this type of surgery on the lumbar spine.
Do you feel that there is growing interest and acceptance in this procedure today?
Well, when 70% of the pain problems in our pain clinics in this country are due to the so-called fail back, there's a lot of honest surgeons that are giving the disc operation another look and trying to find a better way. Because there's no question but our success of curing the patient of all disabling pain, patient with disc troubles, is a miserable failure among the neurosurgical community.
What do you think accounts for the much higher incidence of surgery for lumbar disc disease in the United States and, say, Western Europe at least, specifically France and Germany?
Well, we do about, this was a statistic some time ago, about 250,000 disc operations in the United States in 1 year. In Sweden, France, and Germany, they probably do less than 1,000. Now, I think and the surgeons over there want to know why so many operations are done on discs in the United States and not in Europe. Dr. Alf Nachmanson was asked that question at one time. And the neurosurgeon from the United States, the answer was, well, you only do 1,000 disc operations, but your percentage of suicide in your country is about 75% higher than ours.
Was that an answer?
Well, anyway, it's quite true. Mm-hmm. The disc operations for most neurosurgeons is their bread and butter surgery. Mm-hmm. It's not aneurysms, it's not brain tumors, it's not skull fractures. Most neurosurgeons make their living on the spine.
There's a lot of pressure, though, on the doctor, not just economics, I'm sure, mm-hmm. Because I doubt very much if a doctor operates for the financial aspect. At least I'd find that hard to believe, wouldn't you?
Well, it's hard to believe, and yet the average neurosurgeon, I think, is too busy. They tell me, we don't have time to spend 3 hours on one disc case.
Yeah.
We've got 7 people in the wings over there that need their sciatica cured, and I can get them in and get their disc out and get them back to work in a couple of weeks. So why should I spend 3 hours or 2.5 hours doing a disc operation? So I think it's demand and volume, and most neurosurgeons, the reason they haven't taken up the interbody fusion operation.
One thing that's a bit exotic for the mainland U.S., certainly not, I'm sure, for Puerto Rico and Hawaii, was your experience with leprosy.
Oh,
or has
that's
been
a
your
long
experience
time
with
ago.
leprosy. Well, I imagine you still see an occasional patient, or very infrequently today.
Very infrequent.
But this is something that I was faced with too, without any at all previous knowledge or experience.
Mm-hmm.
I wonder if you'd just relate briefly, but I think leprosy is, it's sometimes forgotten, is primarily a neurological disease.
Yeah.
And it does have neurosurgical implications on occasion. Why don't you relate a bit about your first experiences with leprosy? And
Well, when the white man first went to the Hawaiian Islands, Captain Cook got there in 1777. Then the missionaries came from Boston, the Christian missionaries in 1820, and they brought their measles and their whooping cough and the diseases that the Hawaiians had no resistance to. And among the diseases, the white man's disease that they brought to the native islands was leprosy.
I'll be darned, it came from North America then.
Oh yes, oh yes. No one came to these islands before Captain Cook discovered them. So they had no contact with the outside world at all.
Well, it was endemic in Great Britain and in Scandinavia for ages, well into this
That's
century.
right. And it came from there to Boston, the United States, and then they brought it down to Hawaii. Well, these white man's diseases wiped out about 80% of the population of Hawaii. They had 4 million people there at one time, and their population went down to about 60,000 at one time. But when I got there in 1938, there were lots of leprosy. In my weekly clinic for the charity patients, I would usually pick up 2 or 3 lepers.
Because the foot drops and wrist...
No. Most of them were
all on
skin
nerve.
lesions.
Oh, it's just plain skin lesions.
Yeah. They'd come in with a sore, and so we had a receiving station for the lepers. They'd keep them there for a week or so and prove the diagnosis, and then they'd isolate them, put them over on Molokai, and they had a little isolated peninsula off of Molokai, which was the leprosy island, and they just dumped the patients there and let them fend for themselves.
There still is a leprosy hospital there, isn't there?
Well, that's a historical thing now,
Yes.
not functional. But when I went there, there were over 400 active lepers in the leprosy hospital. And they had no medical care at all. There's a clinic there that took care of their sores and the likes, and that's all. Well, I went over to the leper colony and saw some of these poor guys with their leprous neuromas, terribly painful things. The granulomas would grow around the peripheral nerves, and it would enlarge and enlarge. Feel as suboccipital nerve would be big as your thumb, and exquisitely painful because the nerve is just being trapped and compressed by this big granuloma. And I found out that I could relieve the pain and relieve some of the neurological deficit by peeling these granulomas off the peripheral nerves. So I went to the leprosy island once a month, the last Thursday in the month, and I did that for 3 years. and operated on all these peripheral neuromas.
A lot of them are at the ulnar.
The ulnar,
And,
the ulnar nerve,
Infrequently the common perineal, popliteal.
yeah, gluteal nerves.
Yes.
So I had a lot of experience with lepers. Well, of course, when Pearl Harbor came along, then we had to stop all of that because
Yes.
I was too busy doing other things.
Now, spinal surgery, apparently, I mean, your interest in spinal surgery and your approaches, especially later to the anterior aspect of the cervical spine, was influenced to some degree, as I recall, by your experiences with tuberculosis of the spine.
No, I think my PLIF operation and the success with the interbody fusion was pretty much the reason for my advances that I developed for the cervical spine, because for years I tried to figure out, now how can I fuse the bodies of the vertebrae in the neck? It works so well in the lumbar region, and I got to be able to do that from the neck. And it wasn't until early in 1956 that I conceived the idea of going in the front of the neck rather than the back.
How did you conceive that?
Well, there was a neurosurgeon down in Atlanta named George Smith. I think he was probably one of the first that did a cervical discogram. Now, I had published several papers on lumbar discography starting way back in 1950.
Now, that was to study the structure of the damaged or normal disc, or to localize
Well, in
pain.
the lumbar region, I was identifying the pathology, the disc pathology,
Right.
whether it was just a simple protrusion or a sequestrum, or whether the patient just had disc pain without sciatica.
Yes, sir.
And I could prove that by the discogram. By injecting an opaque dye into the disc, we could reproduce the disc pain,
Yes.
what I call the discogenic pain.
Right.
So very early in my PLIF operations, I began doing discectomies and interbody fusions on patients that had only back pain and no sciatica. And the discogram would show a very severe, painful, broken up, internal ruptured disc with no protrusion. The disc above and below would be perfectly normal.
Were the results overall as...
Absolutely. If I get that bad degenerated disc out and replace it with bone, in 4 or 5 months, that guy's back on the plantation doing his hard work.
But Dr. Smith's contribution...
Now, Dr. Smith did try the cervical discogram by pushing the larynx and the trachea across and putting a needle in the front of the disc to duplicate what I had found in the lumbar region, the cervical
pain.
region. Now, I visited Dr. Walker early in 1956, and he gave me one of Dr. Smith's cervical discogram x-rays, and then the light bulb come to my head. He's getting into that disc from the front with a needle. There's no reason why I can't get into that damn disc from the front side surgically. And so all that summer I spent on cadavers in the morgue, working out the details of the anterior approach and getting instruments for retraction and for taking the disc out and so on.
Now, Codman and Shirtlift made your first instruments for
Yeah,
that?
I finally got this all worked out by November, and I did my first case in November. My scrub nurse, who was my assistant in all these autopsy experiments, she was a Catholic, and she talked one of the nuns in the hospital who had an arm pain and a typical cervical disc. And of course I had worked out the cervical discogram in the meantime and published my paper on the technique of cervical discography. And so we did our first case on this nun. And the operation was a fantastic success. Her arm pain was all gone the next day. So it worked out very good. Slipped my mind what ask me another question and it'll come back to me.
Thinking that your first general presentation about this, the anterior cervical approach to spondylosis and even acute disc herniations, was in 1958, or thereabouts?
Yes. I did my first case in November 1956. By April of 57, I had done 45 cases. And I wrote a paper on describing this new operation and my results with 45 cases and sent it in to the program chairman of the Harvey Cushing Society. And I wanted to report this new operation in April 1957. I got a letter back from the chairman. He said, "We're sorry, we're not talking about discs this year." So I wasn't able to get on the program, and I didn't describe the operation or get it published in the literature until the following year. So according to the literature, people think that I started this operation in 1958.
Oh.
Actually, I'd been doing it for 2 years when it was finally published. We went to the first International Neurosurgical Congress in Belgium
Yes.
in the spring of 1957. And I read this paper that I was going to read to the Cushing meeting at that international meeting and presented my anterior cervical operation. Now, after I read my paper, one of the doctors came up and he said, "Have you seen the exhibits downstairs?" And I said, "No." He said, "Well, you go down and look at exhibit number 9. So I go down to exhibit number 9, and there was an exhibit by Dr. Derrymaker of Brussels, Belgium. And he described my anterior operation exactly the way I had worked it out. And I asked him where he got the idea. Well, he didn't tell me because he spoke only French. And so I didn't get much from Derrymaker. But there was always a lot of controversy about my approach to the anterior cervical spine.
Realize that.
The first article in the literature was written by Dr. Robertson and Johns Hopkins. And he did an experiment on dogs to fuse the bodies of the vertebrae in dogs. And then he did his first patient. And late in 1955, he had a small little article in the bulletin of Johns Hopkins University describing his interbody fusion in the cervical spine by the anterior approach. Now, when I published my paper the first time, and I worked out the details of my operation, I didn't know anything about Derrymaker because I didn't read the French literature, and I never took the Johns Hopkins bulletin, so I didn't know that Robinson had described this thing. So in other words, the anterior cervical approach was described almost simultaneously in 3 separate parts of the world, and each of these various contributors had no knowledge of the activities of the other 2.
But there were some differences between your technique and those of Dr. Robinson.
Yes, Dr. Robinson was an orthopedic surgeon. His purpose of doing the operation was to develop a fusion.
Yes.
He wanted to get a spinal fusion, period. And in all of his publishes, he says, take out the front half of the disc, put in the square bone graft, and you get a fusion, and the patient's pain will go away. And he said, do not go into the spinal canal. Do not attempt to take out the osteophytes, because if you wait long enough, the osteophytes will go away anyway. So that was his teaching to the orthopedic surgeons. Now, my teaching and my purpose of developing this operation was to get into the spinal canal.
Yes.
As a neurosurgeon, I had to take out the pathology that was situated anterior to the spinal cord that we'd never been able to do by a laminectomy from the other side.
I recall the first presentation that I heard of yours in January of 1959 in Chicago at the Interurban Society. And at that time you presented, as I recall, some motion pictures of patients operated upon showing how you did the operation under local anesthesia, as I recall. And the technique of discography. But the most impressive thing was the rapidity of recovery of some patients, at least for me, the most impressive, of patients who had been confined to wheelchairs for substantial periods of time because of cord compression from cervical spondylosis. And at the time of your presentation, there was this prevailing pessimism about the traditional cervical laminectomy being of much use to treat cord compression. And this,
They didn't believe me.
Well, if I could speak, or if I am representative of the younger neurosurgeons in training and also in practice at that time, we were very much impressed at that meeting and taken up by the idea of here is something that holds promise where we've been taught that cervical laminectomy is likely to fail. And
Yep.
I recall as well there were a few patients who bore the diagnosis of Lou Gehrig's disease, ALS.
Yeah.
Um,
I've had
clinically.
three of those.
Right, and at that time it was very difficult to make it differential sometimes. And so for several years there, before either improvements were made in diagnostic, in methods of diagnosis, some patients would be operated upon and actually be helped because they did not have
ALS. Yeah,
They mimicked
the symptoms
ALS.
are very, very much the same.
Yes. And that was another very important aspect. I remember some people thinking that you were trying to maintain that you had found a surgical cure for ALS, which was a complete misunderstanding.
Yeah, another diagnosis.
But about the anterior cervical approach, you had mentioned to me earlier that there was this very slow acceptance of the operation.
Oh, yes.
Why?
It's very strange why people are reluctant to accept new things. And the anterior approach, for some reason, just did not click with the average neurosurgeon. Your group that you mentioned in Chicago were looking at it from a practical standpoint, but it took almost 10 years from the time I published my description of this operation before there were very many articles appeared in the literature where others had taken up the operation, had found out that what I said it would do was correct. And during that 10 years, I was damned and criticized by everybody. It was a real hard period to go through.
I do remember one comment made by a senior neurosurgeon, whose name I don't recall now, and I don't mean this to flatter you, but during the question and answer session, he said something like, well, it's all right for you, Ralph, to do an operation like this. We know how skillful you are, but we're just poor, plain neurosurgeons, as though this was a very intimidating operation for the average neurosurgeon to undertake. And perhaps that influenced a lot of
Criticism?
Well, not the criticism, but reluctance or delay in incorporating it into their armamentarium. I think that may have been a factor. I'm not certain.
Well,
but I think that the other major delay was related to the subsequent later reports of various complications associated with the procedure. And I wonder if you'd care to remark about them. These are not in your papers, but...
Yes, I've had this comment many times. Well, in your hands, you can do this lumbar operation and you have excellent results, but we're not the technicians that you are, and that always makes me mad. Because if you're going to be a neurosurgeon, and I said, look, the first suprachiasmatic meningioma you ever did, you probably spent about 7 or 8 hours dissecting this away from the optic nerves and so on. I said, why aren't you willing to give equal time to fixing a man's back that he's going to have to live with for the rest of his life, for 40 years? I mean, making examples like that kind of made guys mad, you know?
Sure.
Let me read this just for the fun of it. Except for a few brave pioneers, the anterior cervical operation was not accepted until nearly 10 years later. And the reason for this slow acceptance was described by one of my favorite philosophers, and I quote, It seems as though by some particular maladjustment of human nature that man must always doubt, must criticize, must condone new ideas, whether they be of spiritual or material foundation. Never in the history of the world has a new idea, later proven true, found ready acceptance. Man, it seems, must learn the hard way. He must deny and attack instead of investigating. He must battle with all his powers against the introduction of new things instead of utilizing them immediately to his advantage and benefit. He must blind himself with prejudice instead of allowing the clear light of reason to make visible the advantages of a new departure. And I think that probably is why so many new things like this are not accepted immediately, because it's just human nature.
Yes. In 1988, when you were honored at Rush Presbyterian St. Luke's, your old medical school, for your distinguished achievements, you had remarked, or rather, Dr. Whistler, the chairman of neurosurgery there, had remarked that achievements in science, if not in every creative endeavor, are those of individuals. Mm-hmm. I wanted to ask, before we sort of wind this up, about two other aspects of your surgical career. One is something that not very often is encountered in the mainland again, and that is of the hyperhydrosis, and the development as a consequence of that of your upper thoracic sympathectomy, which is a very neat operation. I wonder if you'd just elaborate a bit on that.
Yeah. Well, I encountered this soon after I arrived in Hawaii. Young patients would come in with these sweaty hands. And I mean, their hands would literally drip. They'd shake their hands like this and look like it had been raining on the floor. This was a horrible affliction. And I found out in tracing these cases that, in the first place, it seemed to be familial, because I'd find several members in one family. And second, in reviewing a series of cases that I got later on, most of them were Japanese. So it was not only a familial and a hereditary disease, but also a racial. Even more so, most of the Japanese came from Okinawa. And the Okinawans are a particular type of Japanese, yes, that have a lot of body hair and so on. Mm-hmm. And most of these young kids that came in with their hands sweating had Okinawan ancestors. Well, this is a very terrible affliction, particularly in young people and young adults. I noticed that the young girls would be in their mid or late 20s, and they'd never got married. And the reason was they could never hold hands with the boys.
Yes. He'd
give them a wet fish. An occupational hazard. Secretaries trying to take dictation with shorthand, and their hands would perspire, and when they get back to their desk with their notebook, the sweat had smeared all of their pages and they couldn't tell what they'd written. Mm-hmm. One man was an architect, sitting at his architecture board drawing blueprints, and he had a pile of handkerchiefs about that high at the start of the day, and every line he'd draw, he'd have to stop and wipe his hands. Mm-hmm. So this was a terrible affliction.
Well, and bilateral, by the way.
Yeah, it was always both feet, and about 20% of them, both hands, about 20% of them, the feet also. Mm-hmm. Well, anatomically, the sympathetic control of the pseudomotor function in the upper extremities is the second thoracic sympathetic ganglion. People had attempted to remove this ganglion surgically by going in the axilla or transthoracic or some
supraclavicular even.
Yeah, or supraclavicular, some surgical approach that had a very, very poor result and poor prognosis. Well, I worked out the details of this operation by making a midline incision over the second thoracic spinous process above and below. And a costotransversectomy, taking off a transverse process and the rib, will drop you down in the paravertebral gutter. We had to disarticulate the head of the rib from the body of the vertebra and take the rib out.
That takes a little bit of time.
And that drops you right down into the paravertebral gutter, medial to the pleural reflection. And there you can get at the sympathetic chain and the second sympathetic ganglion. And I learned after a couple of cases that if I resected the ganglion, the chain would regenerate, and about 2 years later they'd start sweating again. So I thought, well, I can't do that. So I did a ganglionotomy. I would cut the pre- and post-ganglionic fibers to the sympathetic ganglion, and then cut the chain down at T2 or T3, and take the chain outside of the chest and sew it on the back of the rib. Now with the distance between the two ends of the sympathetic chain that far apart and outside the chest, there was no chance that the thing could regenerate.
And there was
so once I did that, then I followed these cases for 25 or 30 years, and they never sweat again.
I imagine the instance of ptosis was very, very small, Horner syndrome.
Well, you've got to get the stellate ganglion to get
Right,
a ptosis.
but I meant retraction downwards. You didn't have to retract.
No, not at all.
No.
No, because this operation drops you right down onto the second chain, the second ganglion, and cutting the pre- and post-ganglionic fibers to the second intercostal nerve. That loosens the chain up, and then you can just put it outside the rib.
And
if you get above and get the first sympathetic, the first thoracic, or up into the stellate, then you're going to get a ptosis.
Right.
I only had one patient with a ptosis, and he had had a previous operation by the transaxillary approach, and the whole area was scarred up. And
for hyperhidrosis of the feet, you would do a conventional lumbar sympathectomy.
Well, I discovered, it was interesting, and in my second paper on hyperhidrosis, there was about a 30% of people that we did the second thoracic sympathectomy that their feet were dry too.
Those pathways are intriguing.
Well, the reason was I speculated that instead of the pseudomotor function going down the sympathetic chain, it went down the spinal cord and then came out of the lumbar roots to the lumbar ganglion and made the feet sweat. Otherwise, why, if sectioning this chain, would it knock out their
Roughly
their
what
feet?
percentage of those who had both hands and feet affected would be relieved in the feet?
About 20% of
20%?
Yeah.
That requires looking into, you know.
Oh yeah, they walk barefooted down on the floor, and you see they leave footprints behind them.
And then there are two other fields of surgery. One, you had told me when we were talking some weeks ago about your experiences with leucotomy or lobotomy.
Prefrontal lobotomy.
Yes, sir.
Yeah.
And I wonder if you would briefly describe your technique and the indications and your results. I believe you mentioned there were about 900 patients you had operated upon.
No, not that many, about 500.
500.
The lobotomy operation I learned from Dr. Watts and Dr. Freeman. I went back to Philadelphia, and that was a very interesting team, because Dr. Freeman was a psychiatrist, and Jimmy Watts was a very good neurosurgeon, a good technician. But the team were always in the operating room, and Dr. Freeman was on the other side of the room. Dr. Watts was putting his lobotomy knife into the frontal lobe, and Dr. Freeman was down there like a surveyor, telling him a little more here, a little more there, and giving him instructions of how to do his operation. It was very interesting. Well, I used Dr. Watts's technique. The trephine was made 3 fingers breadth above the zygoma, and just anterior to the coronal suture. A little nick was made in the dura. The brain puncture needle would go all the way into the falx, so you'd know how far to go. And
be
then
in
the
front of
lobotomy
the
knife,
horn, yep.
the lobotomy knife was a blunt, flat knife with a vertical stick here so you could keep it in the right plane. And the idea was to pass the knife through the cortex of the frontal lobe all the way up to the top and all the way down to the bottom, so you make a fan-shaped incision through the prefrontal white matter. And this had to be done bilateral on both sides. We had no mortality whatsoever with the operation. The patients I chose to operate from the very beginning were people that had been committed to our state hospital, or the territory at that time. The crazy house, as the Hawaiians called it. The patient had to have been in the hospital a minimum of 3 years and had been resistant to any type of treatment, including shock therapy and everything else.
What years?
For 3 years.
This was in the 40s now?
Yeah. I think I started the lobotomies about 1939 to 1940. And we did them for about 10 years. And I did over 500 cases.
This is primarily manic depressive disease, schizophrenia, and
paranoids.
And
chronic paranoid.
severe obsessive compulsive.
Obsessive compulsive
patients.
behavior. The paranoids were the most interesting.
Were they improved or just sedated?
No. It completely reversed their psychological problem.
Delusions?
Absolutely. The paranoid was, well, a good example. I had a colored man who came to Hawaii to get a job. He had killed 4 people. Always, he said, in self-defense, and the courts turned him loose. But he was a murderer because he was paranoid about his race. And his paranoia was so bad that they didn't have to say anything about his race, but they'd just kind of look at him out of the corner of his eye, and he'd get violently mad and grab a knife and stab him.
Almost like a muck.
He was just wild.
Uncontrollable.
Well, he got a job with a roofer, and he had stabbed one of his companions up putting a roof on the building, and that's how he got in the crazy hospital. And they had him in a straitjacket half the time because everybody was afraid of him. He was mean. Well, we chose him. He hadn't been in there for a long time, but he was. They sent him out there instead of sending him to jail, because there wasn't any point putting him in jail. They'd have to lock him up anyway, and so they had him locked up.
Yes.
So I did the lobotomy on him, and the following week, I went out to see how he was. And he was sitting out in the yard of the hospital with one of these old spittoons, and he was shining it. And so I come up and I said, "George, if somebody calls you a dirty black nigger, what would you do?" Now, if I had made that statement before I operated on him, I'd want about 2 weeks head start.
Yeah.
Well, George sat there and went right on shining his pan. And then he raised his eyes and he said, nothing, I guess. And that was his reaction.
Was the improvement sustained?
Completely. The hospital let him loose in about 3 months when they proved that he was absolutely stable. Nothing they could do would make this guy go into violent behavior. And they put him out in the community, and the guy that had the job where he was doing roofing, he started working for him. He worked for him for another 2 or 3 years before he left the island.
Now, the other patients on whom you operated, was there any category of patient who subsequently relapsed after a period of months or a period of year or two?
The psychologist at the university, I'll think of his name in a minute, he did a very extensive battery of psychological examinations on all of my prefrontal lobotomy patients before the operation and after the operation. And he followed these patients up to about 5 years. And he wrote a monograph on this experience, showing the value of his testing and so on. And these are all patients that I'd done the lobotomy on. He had all the statistics of the cases. 80% of the lobotomy patients that I operated in that institution were discharged from the hospital and put back into the community.
Not to return.
Not to return.
And not even on follow-up medications, because I imagine at the end of that decade, Thorazine was commencing to appear.
Well, the only problem we had was epilepsy, because
I was
very
going
often
to ask you about the instance of
very
seizures.
often they'd get epilepsy.
Do you think that was because of the
most of them
location of the cortical lesion?
got grossly obese. It changed the physiological metabolism of the body, that lobotomy did. But as far as their mental behavior, they were all very, very stable, stoic patients.
Do you think the instance of seizures following the lobotomy, the technique you employed, was related at all to the location of the cortical incision?
No. The
That
cortical
the
incision wasn't any bigger than 2 or 3
I understand,
millimeters.
but that, say, the Lyerly technique that Dr. Poppin also used was
Transfrontal?
Yes, sir. And,
Or supraorbital?
Yes, and
Yeah,
I
Dr.
don't
Freeman
know.
used to do it himself in his office with an ice
No,
pick.
it wasn't that. No, it was just about 3 centimeters from the midline.
Yeah.
And just in front of the coronal, but in an area where apparently the cortex is a bit more resistant to the development of a seizure focus. I was just wondering if that's true. I don't know.
Well, I think the approach, the frontal approach here, there's probably more danger of damaging cortex. I don't think the seizures came from the subcortical white matter. And the violation of the frontal cortex with the operation Dr. Watts did and I did was only a couple of millimeters, just big enough to put a brain needle in.
Well, the last of the surgical procedures was that of Parkinson's in 1940. 1950. You commenced to operate upon patients. Was it in 50 or the early 50s?
Well, I'll get on to Parkinson's in a minute. Why do you think the lobotomy operation suddenly came to a screaming halt?
Primarily Thorazine and the public outrage about
destroying the brain, quote, end quote.
Well, a lot of the operations were done in mental hospitals by people who were not surgeons.
Yeah.
And they were often not even psychiatrists.
Yeah.
And the patients did not have adequate psychiatric evaluations or diagnoses.
Yeah.
And it did give it a bad name, yes.
That's right.
And then Thorazine appears about 1950.
Yeah, the tranquilizers
54.
began to do things that the lobotomy did.
But there was that terrific fear, as we have today, of prisons, of cells, that our mental hospital needs beds by the year 2000 were projected to be, something like 10 million. That was before, any Thorazine or any of the other drugs came out, but they looked very gloomy.
Well, like my black man, I'm sure the prisons are filled with murderers that have chronic paranoia that could be cured by lobotomies.
And also may have some spike discharges, too.
Yeah.
But
now, the Parkinson's disease, Dr. Irving Cooper was the one that started the Parkinson's in 1956. And I went back to St. Barnabas Hospital and spent 2 weeks with him and saw his patients. He had gone through the vascular clipping, the chemopalliidectomy, putting a little needle down into the thalamus and that had a balloon on the end of it, and the balloon would make a little pocket, and then he'd inject alcohol into the area. And he gave up that idea, and finally settled on the McKinney technique, which I used for about 10 years. Bill McKinney's a little stereotactic device that you put into a trephine hole in the skull, and had a movable platform so you could put the needle in any direction. We would put the trephine hole up on the top of the head and do a ventriculogram, and then mark the area we were going to cut out, the ventrolateral nucleus of the thalamus. You needed to make a lesion about as big as your fingernail to stop the Parkinson's.
how often?
And these were patients that had the violent shaking that was so incapacitating.
Did you start with pallidotomy, though?
I tried that, yeah. And I also tried the freezing method.
Right.
He got the needle with a tin.
Yes. I recall that.
It would make a little ball of ice on the end
Yes.
of it and freeze the brain. But the little wire with a loop on it, the McKinney's, you could control the cutting. They were afraid that we'd cut blood vessels and the patient would get a hematoma right next to the pyramidal tract and end up hemiplegic. But I had no hemiplegias in all the cases I did.
Did you eventually, how many did you eventually operate upon?
I probably had around, 200 to 300 Parkinson's cases.
Did you have some where you had to reoperate?
Yes.
I think that was everyone's experience. Really.
Yeah, very few of them, but some of them we had to do over.
Do you feel that there's a place still for functional neurosurgery for Parkinsonism today, in spite of L-DOPA?
I certainly do. I certainly do.
What do you feel are the indications?
The last Parkinson's operation I operated on was an old Japanese doctor. Well, I say old, at that time he was in his early 60s. But he had a unilateral tremor in his right hand. And his hand would shake just like that. And it was terribly incapacitating to him. He was still trying to practice medicine. And he spent half his time with that hand under his thigh to hold it still. And I did a unilateral operation on him for the Parkinson's disease. And of course we do them under local. And this is very emotional because I had the needle up there in his brain ready to go, and he was sitting there. His hand was shaking away. I said, okay, now I'm going to turn the light off. So I turned the little needle like that and cut the hole, and suddenly his hand stopped. And he put his hands out like this. And instead of this one shaking like that, it was perfectly quiet. Then he started to cry. The tears rolled down his head. First time in about 8 years that hand had stopped shaking. Well, he went back to his practice, and he lived almost 10 years after I did that operation on him, from 72 until 82, 83. No recurrence. He developed a little shaking in his other hand, but not violent like this one was. Now, when you get an operation that is so benign, so simple to do, and so fantastic in its results, instantaneous, I see absolutely no reason why we shouldn't be giving our fellow men the benefit of that type of surgery.
Rather than
filling them full of pills.
Which quite often, have their own side effects.
All that L-DOPA and all the stuff that they have to take out. There's no comparison between the medicine
What then
and
do you
surgery.
feel are the indications today for the surgery for Parkinson's disease? Unilaterality, I suppose, would be one.
Well, the thing that was most spectacular in that operation was the cessation of the tremor.
Yes.
And I'm sure the people, the psychiatrists, whoever give the L-DOPA, and the neurologist, they try to lower the rigidity form of the disease that is so handicapping. But they don't see much spectacular results in stopping the shaking. And to the patient, I think the rigidity is secondary, and like this old doctor, his violent shaking was the thing he wanted to get rid of. Now, I think we ought to combine the two, and if you've got a patient that has violent incapacitating tremors like this, that you can stop surgically, and then give them the L-DOPA to reduce their
So it's not
rigidity.
necessarily either or.
No, I think the tremors are the handicapping and disabling part of the Parkinson syndrome.
Yes.
And that is certainly a sure cure for this operation, and the operation's so simple to do.
I think, I'm sorry our time is nearing its end more or less, but I wanted to ask you what your thoughts might be about the sort of an ideal content of training for neurosurgeons. Of course, we're always learning, so I meant the formal training.
Well, you see, my entire 50 years of neurosurgery or more has gone by in a very isolated environment. I was put on an island out in the middle of the Pacific, 2,000 miles from my nearest consultant. If I wanted to consult with a neurologist or somebody else, I had nobody like that to help me. If I had a hospital with 15 or 20 or 30 patients, I had to change all the dressings and I had to change all the bandages. I had to write all the histories and the orders and the whole thing. In other words, my entire neurosurgical life has been a one-man team. I've never had residents with me. I've never had a retinue to follow me around and to learn from me or to do some of my scud work. I've had to do it all by myself. So my experience in academic neurosurgery has been practically nil. Now, I cannot give advice to the neurosurgeons that dedicate their life to the teaching of young neurosurgeons, tell them what to do and what they should do and should not do. But I might make some comments about the new brand of neurosurgeons that are coming out today. My primary interest, of course, in the last few years, well, as a matter of fact, I stopped doing craniotomies about 1974, 75. So for the past 15 years, I have confined my practice entirely to the spine. And almost every year I send a paper into the meetings to try to get on the program. And I always get the same report, we're sorry, the program is already arranged, and apply to the program chairman next year. So I haven't been on the program very many times. And it seems to me that papers on the spine don't seem to have very much interest to program chairmen. And if you look at the publications in the Journal of Neurosurgery and look at our programs, the AANS, well, I figured out at some time, the spine in the past has covered about 3 to 5% of the publications and the presentations at the meetings. Now, if the young neurosurgeon coming out of his training period expects to spend 92% of his time doing brain tumors and aneurysms and intracranial hemorrhages and hydrocephalus and occasional head injury, they're not going to be able to make a living, because you know and I know that the average young neurosurgeon going out in practice, the majority of his patients are going to be spine patients and not brain patients. And yet it seems that the training programs today, the spinal teaching and the experience that these young fellows get in their training is woefully inadequate compared with the brain treatment.
Well,
they learn to use a microscope. They tackle the big tumors and the aneurysm and everything of the microscope. Then you give them a spine case, give them a broken neck or something, and they want to do it under the microscope, and they want to do just a little bit of here and a little bit there. There's too many lawsuits from what I would call very poor surgery on the spine, done by surgeons who probably have not had adequate training experience in their training program. And hardly a week goes by I don't have a long-distance call from some lawyer. Want to know if I will testify in a court against some doctor that had left a patient quadriplegic because they did a Cloward operation.
how about trauma?
Well,
Do you feel?
spinal trauma today, I think at least 85% of trauma cases that come into the emergency room go to orthopedic surgeons. The orthopedic
Why?
surgeons have,
Why?
well, they've got a different philosophy than the neurosurgeon. The neurosurgeon's philosophy is to treat the nervous system.
Yes.
And when you start talking about a spine and spinal instability, even though you say, well, the neurological deficit is due to spinal instability or to malalignment of the spine. If you're going to treat the neurological deficit, you've got to treat the spine. Well, that's an orthopedic job, so they get their orthopedic colleague to help them. because they weren't trained to take a crooked spine and put it back in
Do you
position
feel
and lock it there.
do you feel we should be?
I do.
Do you feel that neurosurgeons should be trained to be able to operate upon every form of, or more or less every form of spinal instability?
No, I think the orthopedic surgeons should have the training to put these metallic implants for instability. The plates and screws, the big long rods for scoliosis. Dr. Steffi up in Cleveland, who has got these plates and screws now, has convinced a lot of neurosurgeons that people with pseudo-spondylolisthesis and regular spondylolisthesis should have the plates and screws put in to prevent slippage until the patient gets a fusion. Well, maybe that's all right if they want to learn how to do that. Spondylolisthesis has been my favorite interbody fusion operation. I did my first one in 1946. I've done almost 200 spondylos now with interbody fusions. I haven't used plates and screws on one of them. My percentage of cure of spondylolisthesis up to the 3rd degree dislocation is higher than my PLIF operations.
Would you use anterior approaches?
No,
for the most marked?
no,
absolutely
not.
Never?
Absolutely not.
Yet there was a doctor.
You can get a better interbody fusion and an easier technique of reducing the dislocation by a posterior interbody fusion than by an anterior. You'll find anomalies in the spine, in the spondylos, in the position of the facets and so on, that compress the nerve roots, that you can take off posterior, that you can't handle if you just do it interbody fusion from the front side. It's like the anterior cervical operation. When the pathology is in the front of the spinal cord, you're not going to be able to cure the patient by taking these lamina off. Now you reverse that in the lumbar region. Why just take the disc out and put some bone in the disc space when he's got big osteophytes and protruded discs and abnormal facets in the back of the spine that you should be addressing as part of your surgery?
Yes.
So the posterior approach in the lumbar region is the answer to all lumbar spine pathology.
But the doctor in Hong Kong who had developed the approach anteriorly for spondylolisthesis and disease of the body and all, was there anything intrinsically wrong with his conception for that operation?
No.
Or, I know it's
that was Dr. Hodgson.
It's a difficult exposure.
Dr. Hodgson had a lot of tuberculosis in the Chinese when he went to Hong Kong. And back in the early 40s, he was doing transabdominal approach and removing caseous vertebral bodies and replacing them with bone and curing the tuberculosis. When I started the anterior approach, Dr. Hodgson started to do these cases in the cervical region. And it was very interesting. If you get TB of the cervical spine, the tract that the purulent material chooses to get to the outside is posterior to the carotid artery. So Dr.
Posterior to the sheath?
Yeah.
Oh, I didn't know that.
So yeah, it's always back in that area. So Dr. Hodgson always did a posterolateral approach to get into the TB and to the body of the vertebra. And I said, Hoddy, if you're going to get to the vertebral body by that approach, you've got to go through the sympathetic chain, and you're bound to get a Horner syndrome.
Right.
Oh yeah, he said, I get Horner syndrome in all of those cases. But he said the Chinese, they don't care how their eyes look.
Well, that's not quite correct.
Yeah, that's true. But that was his wisecrack about it.
Women.
It wasn't true.
I hope, I think we all hope that you will find the time and energy to put together a book about your spinal surgery over the years and in detail and at length. And just one last question. Do you have any idea that's hung with you over the years, both in medicine and especially in neurosurgery, either something that you acquired on your own or something from some teacher that has stood you in good stead over the years in medicine?
Well, if I had to give advice to a new neurosurgeon, we've got to realize that as human beings, we're not all the same. Some of us have, I say us, I think intrinsic abilities that other people don't have. Some of the greatest neurosurgeons that have had the greatest impression on the development of neurosurgery technically were not good surgeons. That is, from my appraising the technicality or technical ability of neurosurgeons. And I think young neurosurgeons ought to realize that, well, in the first place, they can't play God. They can't think because they've gone through 5 or 6 or 7 years of training that they can do anything and do it right, because someday they're going to wake up and find out that maybe they're not as technically as good as they thought they were. I think all people ought to do a little self-appraising and be a little bit more humble in their practice of neurosurgery, because it's a tremendous taskmaster, and you can't be an expert in all things. And it's probably better if you realize that and make a self-appraisal of your abilities in your practice as you go along.
Well, I want to thank you very much, Dr. Cloward, for an interview I'd been hoping we would finally make for the past few years.